Okay, so moving into conditions, we have acoustic neuroma. So the pathology of an acoustic neuroma is all about its location. So it's a slow growing pathology and it will involve primarily the eighth cranial nerve. So it's a nerve sheath tumour growing itself from the eighth nerve and it's hemmed in. So that's why we call it a cerebellopontine angle. So it's hemmed in by the pons on one side, the cerebellum, and then the petrous bone. So expansion is confined by those three sides. Because of where it is, it generally presents with cranial nerve 8 deficits. So sensory neural deafness, sometimes vertigo, but more rarely. And as it gets larger, it can then impinge on the trigeminal nerve, causing pain and paresthesia, which can be misinterpreted for trigeminal neuralgia. So if somebody has new deafness, new vertigo and imbalance, and trigeminal neuralgia, then think about a structural pathology like a cerebellopontine angle tumour. If it gets to about more than 4 centimetres, it can then begin to affect the cerebellum as well, and people can get cerebellar compromise, so ataxia, incoordination, nystagmus. Now, when you investigate a suspected cerebellopontine angle lesion or an acoustic neuroma, look at the hearing loss especially, and when you tailor your examination, look specifically for cranial nerve deficits that are adjacent. So deafness, so remember your Weber's test and your Rinne's test, you're looking for sensory neural deficit. Look for a loss of the corneal reflex on that side, and also maybe cerebellar features on that side. If you send to ENT, they might do more sophisticated audiology testing, which we can't do. We pretty much can just use our voice and a tuning fork. But it can be helpful to look for subtle deficits to get ENT to do that. And MR is much more helpful to look for an acoustic neuroma. It enhances with IV contrast, IV gadolinium, and we say it contrasts avidly, so it lights up. And the treatment can be divided into 3 approaches, pretty simple. So one is conservative, so that's particularly helpful if people are quite reluctant to have surgery or very frail. If there is no growth after 1 year, which about half of people won't have any growth after a year, and it's a very small tumour, less than 2 centimetres. If there are few symptoms and patients are elderly, that's an appropriate way of approaching it. And you would need to have serial scans for that. Radiosurgery or stereotactic radiosurgery can slow the growth of a acoustic neuroma by up to 90%, which is really impressive. That can preserve your hearing, it can preserve the facial nerve, movement of the face, and that's much more commonly used nowadays, and it's less risky in terms of surgery in general. Now, surgical resection, so proper open surgery by a neurosurgeon, it's the only feasible option if it's a very large tumour, bigger than 3 centimetres, and if there is already cranial nerve deficit and you're worried, obviously we're worried that other cranial nerves will become involved, or this hydrocephalus, if there's a blockage due to the size of the tumour preventing drainage of CSF. And there are several different approaches, the direction in which the surgeons would approach to do that.